Hello and welcome to Health Professional Radio. I'm your host, Neil Howard. Thank you so much for joining us for another segment. We're going to be speaking with Dr. Mazen Dimachkie. He's joining us here from the University of Kansas Health System to discuss Pompe disease. It's a progressive muscular disorder. Welcome to Health Professional Radio, Dr. Dimachkie.
Thank you for the invite, Neil. It's great to be with you and with the community of patients with Pompe disease. I'm glad to answer your questions here.
Great. Well, I do understand that you're a Neuromuscular Division Chief at the University of Kansas Health System. Give us a bit of your professional background briefly and talk about what it means to be Neuromuscular Division Chief at the University of Kansas Health System.
Yes. I trained in neurology initially, and after that I did a fellowship training in EMG and neuromuscular disease, and I've been in the neuromuscular field since 1994, initially on faculty at the University of Texas Houston Medical School until 2007. In 2007, I joined the neurology department at the University of Kansas Medical Center, and currently I'm Professor of Neurology, Executive Vice Chair in the Department of Neurology, Vice Chair for Research Programs, and I'm the Program Director for the Neuromuscular Medicine Fellowship at the University of Kansas Medical Center, and I'm the Chief of the Neuromuscular Division. So multiple hats here, but the bottom line is I have a passion for neuromuscular disease, including Pompe, and advancing the care of people suffering from Pompe disease.
Well, in simple terms, what is Pompe disease? Explain it to our listeners, including some of the signs, some of the symptoms, what causes it, and who's affected. I know that's a lot to explain in just a couple of minutes.
Definitely. Pompe disease is a progressive and disabling muscle disorder that impacts the ability to move and to breathe, put it simply. It's a very rare disease. It's autosomal recessive. It's a lysosomal storage disorder. By saying it's autosomal recessive, it means that it requires a gene mutation to be passed along from each of the parents to cause the disease. Thereby, healthy parents can have one or more child who will have Pompe disease. Pompe has two different forms. One of them is a more severe form that begins in the first year of life. It's called IOPD, or infantile onset Pompe disease. It also has a more delayed, milder form that begins manifesting after the first year of life. It's called late-onset Pompe disease. It's abbreviated as LOPD. The cause of Pompe disease is deficiency of an enzyme called acid alpha-glucosidase, oftentimes we abbreviate it as GAA. And this enzyme is responsible to breaking down complex carbohydrates called glycogen within the lysosomes of muscle cells. In Pompe disease, because of this enzyme deficiency of the GAA enzyme, glycogen accumulates in skeletal muscles, in cardiac or heart muscles, but also in smooth muscles that line blood vessels. So this leads to storage of glycogen into organelles in the cells called lysosomes, and that in turn leads to irreversible damage to the muscles, affecting thereby the strength, the mobility, and the breathing apparatus. From a prevalence standpoint, Pompe is an ultra-rare disease with a prevalence in the U.S. of approximately, and there are ranges there, but approximately 1 in 28,000 people. The majority of cases are of the late onset type, or LOPD.
Now, understanding that it presents in two different forms, the early stage and the late onset, are either of these more susceptible to misdiagnosis than the other, or is Pompe disease normally misdiagnosed as something else until someone knowledgeable makes a correct diagnosis?
I think that the misdiagnosis and the diagnostic journey in Pompe disease is quite lengthy. I think with the infantile form, there's clearly a presentation early on in life of what we call a floppy infant, an infant that has profound muscle weakness, that has difficulty with breathing, with sucking on food, and that kind of create a higher index of suspicion for Pompe disease. Couple that with the fact that many states have incorporated in their screening panels for gene disorders, Pompe disease, that has expanded our ability to recognize the infantile onset form early on. What, however, is more difficult to diagnose is the later onset forms, especially in those who are not born in recent years, where newborn screening has been implemented and remain to be a diagnostic challenge. I think I would like to thank you for giving me this opportunity to speak with you, to raise awareness about this rare yet treatable inherited muscle disease. Oftentimes, Pompe diagnosis, especially the late onset form, is delayed for more than a decade in some cases due to its similarity to other muscle diseases that impair function. It can present with shortness of air due to breathing muscle weakness at a time when there's little or no limb muscle weakness, making it even more difficult to recognize. This long diagnostic journey leads to delay in treatment and to disease progression. And when diseases like Pompe disease, time is everything. Nexviazyme is the name of the new enzyme replacement therapy that the FDA approved. There's, like every drug, there's a brand name and there is the generic name, which is the chemical composition name. Nexviazyme is the same as avalglucosidase alfa. What Nexviazyme consists of at a structural molecular level is a modification of the deficient enzyme. The acid alpha-glucosidase is deficient. It's a modification of that. So Nexviazyme is really designed to have a larger number of something called M6P, which is mannose 6-phosphate residues. Namely, Nexviazyme has 15, each Nexviazyme molecule has about 15 mannose 6-phosphate residues on it, as compared to the native normal GAA enzyme, which has only one residue. So what does this mean in practicality? Well, this modification works through multiple pathways, but one of which is to allow for Nexviazyme to go into the muscle cells with greater affinity, greater ability by binding to a receptor for that M6P on the surface of muscle fibers. And we think that better enzyme entry into those damaged cells may lead to more clearance of the byproducts, the accumulated glycogen, and therefore better muscle health.
Where can our listeners go online and get some more information?
I think that going online is something that I'm sure our listeners will do, but I think the first step is consulting with your treating doctor who's managing your Pompe disease. I would suggest that would be an excellent resource for information about new drug discoveries, including Nexviazyme. The FDA package insert also provides useful information about Nexviazyme, so searching for package insert FDA Nexviazyme online would be another way to approach this. But there are many benefits to Pompe patients seeking care at centers with expertise in this disease, so your doctor is your resource. And I strongly believe in empowering patients and their families by educating them about their disease and providing reliable sources of information, because as we know, the internet is a good place, but it's not a perfect place for information. I think it's important that cutting-edge access to therapies be provided to patients, and that there's an opportunity to learn about ongoing research from your doctors. This way, Pompe patients will be sophisticated consumers of healthcare as they navigate their diagnostic and therapeutic journey.
Well, Doctor, I appreciate you joining us here on Health Professional Radio. I'm hoping that we'll have an opportunity to speak again.
I look forward to it too. Thank you.
Thank you. You've been listening to Health Professional Radio. I'm your host, Neil Howard, in conversation with Dr. Mazen Dimachkie. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes, listen in, download it, SoundCloud, and be sure and subscribe to our YouTube channel at youtube.com, Health Professional Radio.